Hello and welcome. Welcome to today's program and thank you for joining us. I'm C. Virginia Fields, former Manhattan Borough President and currently the President and CEO of the National Black Leadership Commission on AIDS, Incorporated. The mission of the National Black Leadership Commission on AIDS is to educate, mobilize, and empower black leaders to meet the challenge of fighting HIV, AIDS, and other health disparities in their local communities. Today's program is part 2 of a 2-part series where we are talking about the connection between stigma and the high rate of HIV, how shame and fear of being ostracized inhibit open dialogue about risk factors, fuel misperceptions about how HIV is transmitted, discourages people from getting tested and seeking treatment, as well as preventing people from disclosing their HIV status to their intimate partners. And here today to discuss this topic is Dr. Carol McLean-Long. Dr. Long is an attending internist at Renaissance Healthcare Network. She began her medical career at City College, where she received her Bachelor's of Science degree in biology. And her career has taken her into various levels of educating people as she took on a part-time job as a student teacher at Barnard College, a researcher in cardiovascular and the neurosciences. And after being a researcher for several years and truly committed to becoming a physician, she enrolled in the Medical College of Pennsylvania, where she obtained her medical degree. And it was in the early 1990s that Dr. Long began to embark on a career at Renaissance Healthcare Network, Harlem Hospital, in the Department of Medicine, and there she took the necessary steps to become a specialist in the field of HIV/AIDS, where she has broad knowledge of the virus and how it impacts communities of color. Our second guest is Vaughn Taylor. Now, Vaughn is the Executive Director of Gay Men of African Descent, Incorporated. Vaughn Taylor is a dedicated and experienced social activist, social entrepreneur, and community researcher with more than 22 years of experience as a professional in the field of social services. Highlights of his career include being an alumnus of CDC Institute of HIV Prevention Leadership, working with Cornell University and the Centers for Disease Control and Prevention. Thank you both for joining me, and I'm just so delighted about the work that both of you are doing, because here we are 30 years into the virus, the epidemic of HIV/AIDS, and we're still seeing, especially in the black community, shame, stigma that prevents people from even wanting to know their status. And of course, we know, based on information data from the Center for Disease Control, that African Americans, black gay men, black men who have sex with men, and heterosexual black women are still disproportionately impacted more than any other racial, ethnic, or sexual orientation groups. So we've got a lot of work to do, and we're starting to look at this from several factors, certainly social factors that impact HIV/AIDS, including poverty, education, and so forth. But stigma and shame is something that we don't talk about a lot in our own community. It's something that we've not given the attention to in a way that helps us move that needle. So you're being here today, we're going to talk about it, and we're going to inform our audience and talk a little bit about what it is that you're doing and what we can all do together. So Dr. Long, given your long-standing work in this field, what are you seeing, and how do you see this thing of stigma and shame and its impact on our being able to more fully address HIV/AIDS in the black community?
I think part of the stigma for us in the Black community is because stigma has to do with a little bit with our culture. We're a society where people are supposed to have children, and children are not supposed to be seen, and they're not supposed to be heard. And there's certain things that you don't talk about. There's certain things that you just kind of put it in the background. You just don't mention that in public spaces. So since we have that idea that certain things are private, it's very difficult when an infection that's related to sexual activity, which is very private in our community, is now have an association where there's disease. So I think that's the biggest thing for us in terms of stigma. Once we learn to accept that sexuality is a natural fact, and the fact that it may be associated with infection, I think we'll be able to come out of the box. But until we can do that, it's going to be very difficult.
And Vaughn, what's your take on stigma and shame in the Black community, and why we had such a hard time in terms of dealing with it and eliminating it?
I agree with the doctor. Very much the case about understanding sexuality as a continuum. That often discussions around HIV is discussion around risk behavior, which bring about shame. And because our communities are so connected, we never realize that the basis of every disease is fear, shame, and guilt. We don't address those things in a way that's actually demonstrable. Ways which you can attack it differently is to start with a very clear, consistent education that because this disease exists, it's just a virus. Once you contextualize it's a virus, we can begin to talk about the social factors that influence disclosure or not. We talk about the appropriate time for sexual debut for youth. Yes, statistics show that kids are being sexually active younger.
Years old. Try that.
Absolutely.
Statistics also show sexuality and sexual expression exists much longer in the continuum. So when you turn 50, your sex life doesn't turn off. We don't give ourselves the space to have really encouraging conversations around that. We don't really talk clearly about condom use, what effective contraceptives are, and when we do talk to people, we talk about it in a shame-based way.
But, you know, I say this to both of you because we're working in this field and we go to these meetings, we go to these conferences. There is so much information out there about HIV, AIDS, how it is transmitted, who the populations that are most negatively or disproportionately impacted, I should say. The information is out there. So why are we still saying we need to do more education?
Good. As he said, it's all about the context of sexuality. We don't want to talk about sexuality, and this particular infection is related to sexuality. We like to see our brothers, sisters, husbands, wives, we know that they have sex, that same sex, but we act like we don't see it and we don't talk about it. And if something happens to them, oh, no, it's nothing. And that's what we have to get away from. We have to talk about sex the same way we talk about bread and butter. Okay, it's on the table. Let's just talk about it. As you spread the butter, you have the conversation. You talk about what is sexuality, what do you expect from a young person, this is what I want you to do, I want you to use a condom, I want you to practice safe sex, I would prefer that you don't do group sex, I prefer that you get to know your partner before you have sex. Those are the conversations that we have to have. And then once you go from that context, then you say to them, and you must remember, condom is now a way of life. It's not something you do when you're going to have sex with somebody who is quote unquote bad or naughty or kinky. No, sex and condoms go together with everybody, no matter who your partners are. And I even tell the people who use toys, your toy gets a condom too. Okay, nothing goes without a condom. And if you start to get that where it's about protecting yourself and not transmitting infection, I think that is the best thing that we can do. And it will decrease the stigma.
The other thing is I think we professionals don't speak English. We get our degrees, we get educated. Stigma is this really abstract concept. And for the average people in the street, we don't break it down. We don't talk about the formation of prejudice, what it looks like in discrimination. I think we have a great opportunity as black and brown people to talk about what it is to be marginalized and then talk about what that experience looks like if you feel you have to keep requests for help secret. If you happen to seroconvert, it's never you just happen to seroconvert. you have
Okay,
HIV.
now so you talk
That's
about
it.
English.
Exactly.
So
Exactly.
right?
Exactly.
Okay. Many people watch, say, okay, he said we're not talking English. What is he talking about?
Great
So,
example. So when you know that you're positive for
Right.
HIV, it's called seroconversion.
right.
The first thoughts many people have is about, well, how do I tell people? How do I hide this contraction of this disease? So from then it becomes a shame-based, secretive conversation. We also don't prepare clients to have a very effective patient-provider conversation. We all go to med. I went to 3 years of med school. So we go into that room and it's a white coat conversation. Whatever the person in the white coat says is truth. We never go in saying, well, I'm an expert on this body. I know this is going to happen, not going to happen. And I may need to talk to my mother, my pastor, my grandmother before I swallow these pills. What would that mean? How do we navigate it? We don't talk about a system that has created perverse incentives for young people. New York City is always in the top 10 most expensive cities in the world to live. I live in Brooklyn. The average one-bedroom apartment in Brooklyn is $13.50. If you make what was currently federal minimum wage, you may on average $12.84 a month, as if you got 40 hours to work. You couldn't make enough. So we provide incentives for people to get engaged in the system. So young people live for 24 years, 364 days, thinking there's a support system. When they turn 25, it drops off. That exacerbates the stigma and creates a false system that some people, because of their HIV status, are privileged or not. That nuance of the conversation makes it very difficult to have safe spaces to say you should use a condom every time, that your HIV status is definitely your business, but it's clearly your responsibility to make sure it's there.
But they see people who are HIV positive getting the resources, getting the rent paid, so it almost becomes, let me become HIV positive, then I will have my resources as I need them, my rent.
That is something that definitively has been happening for years. I think it's starting to slow down now with the fact that all the cutbacks that are coming from the government agencies. But that was something that happened. And another reason why they started to just have sex indiscriminately is because we had medicines. When people were not looking sick anymore, when people were living healthy lives, when people were doing the things that they wanted to do, having children, it's okay if I get HIV positive for the simple reason I know there's a pill I can take and I'll be okay. And that is one of the things that they see, and that's why it makes it okay.
And at some point in this discussion, we're going to sort of put ribbon around everything you said and try to unpackage it in terms of what must be done, given all of the information that's out there, given what we know, and given the need to talk straight.
Yes.
How do we go about doing that? But I really wanted to ask each one of you individually, in terms of the work that you do, Dr. Long, what kind of effects have you seen stigma and shame have on your patients, the people you work with daily?
A lot of them, when they first came in, they worried about stigma and shame, and I'll say at least about 30% of them still do. But what I try to instill in them is this: you are not a disease, you have an infection. And I think that's one of the things that you have to separate for people. It's an infection, just like diabetes, just like cancer, just like kidney disease, just like whatever. You have an infection. You are not the infection. So separate yourself from the infection. And then accept the fact that, yes, something happened and you're ill. But now it's time to look at yourself and say, what do I want out of life? And I tend to, well, browbeat a little bit my clients, because I want you to understand it is just something that happened to you. It's not who you are. So stop it. It takes a long time for people to accept it. And then we talk about, what are you afraid of? So what if they find out? What are you going to do? Leave town? Where are you going to go? You're going to hide in another neighborhood? You're not going to fit in. This is where you live. This is where you grew up. They're going to have to understand sooner or later. And the biggest thing for me is that their families are the ones they don't want to tell. Now, that's a very scary thing for me, where you have an illness, whether it's cancer, diabetes, or HIV, and you can't tell a family member.
It's all related to transmission.
Exactly, exactly. Because then you now know
or intravenous
what I was doing. Okay, you know I was having same sex, or I was having kinky sex, or I was getting myself with an S&M and was getting beaten. So what? What are you doing in my bedroom? You're supposed to be taking care of me, the person, not what I do sexually. And we have to learn to separate it.
And in the work you do, Vaughn, working specifically more with black gay men, men who have sex with men, what are some of the impacts around stigma that you're experiencing in your work?
Sure. So for 6 years, we had a program with the city, an anti-stigma campaign. We talked about it being okay to be open about your status. So one of the great things we know is that many people now come into the office and no longer whisper they're HIV positive, which I think was a great thing, because they'd walk in and it's like, so I want HIV services. Okay. So we talk about that. We helped make it just a status, how to get access. But for those people who are negative, we expanded the conversation to talk about what this means. If we have so many men in our city that are not diagnosed, that may be infected with not knowing, that there has to be a different way of accessing health care. That accessing health care is not an attack on your masculinity, but one way to definitely build it up. Women have it great. You're taught to go to a doctor on a regular basis. You have incredible relationships, and there's a degree of trust where you have a discourse. Men don't have that. We go to the doctor when we're bleeding, the limb is about to fall off, or we have a treatable STI. And we have no relationship to talk about that, so we don't know what medical adherence would mean. We don't know how to ask questions, and we're afraid that if we ask a question in the room, we're going to walk away looking dumb. So we encourage men to talk differently, work on a good English, ask questions, and we do a simple thing for Ask 3. It's like when you go in for any diagnosis, the first thing we want you to do is understand what that diagnosis is. The second, what are the consequences of treatment, not getting treatment? And the third, are you sure when you walk away from this institution, you can do what they ask you to do, or you have someone you can call to help you follow through with the treatment? If not, doesn't matter what disease you have, you're not going to get there. It helps diminish stigma because people can ask questions. The doctor told me to take a pill twice a day. In our agency, we ask, what does twice a day look like for you? If you're like me when I was younger, one somewhere toward the morning, and then again, hopefully before I go to bed. The doctor actually said, take this pill twice a day, 6 hours apart. Well, I've just messed up my treatment. We don't ever have those conversations. Those things help reduce stigma. Ensuring that people can live with HIV, it is a simple status, but then also being able to talk about living without also focusing on risk behavior as a method of disclosure, and encouraging the faith community to come in, because accessing healthcare on a regular basis is one of the greatest social justice platforms I think we've misused in this country.
And I think we talk a lot, we encourage people a lot, certainly in the work that we all do, to share their stories, to talk about how they themselves have responded to having HIV and or AIDS. What examples can you talk about in terms of people who have shown how to cope with stigma, who move beyond that? We don't see as many examples out there of people who are saying, you know, this is how I've coped with it, have overcome, and they become the face. What examples can you talk about?
We have a campaign called HIV is My Reality. It's a visual campaign. We like it because it's a very raw conversation. So we took gallery portraits of, I'd say up to 37 black men now. You see their faces, and then you have the chance to put on a headset and hear their stories. And they tell you what it's like to live with the diagnosis, what it's like to live with the infection. And at the agency, we commonly tell everybody, we're all living with HIV, some of us are infected. It helps to reduce the idea that you're not going to be minimized or isolated, that there's a community here to help you, and also encourage the people who don't have HIV to find out more about how the disease impacts the body, so they really understand HIV is really hard to get, despite the rising numbers. And once you understand that, you can't get it. One of the things I always like to joke about is people, do you think you can get HIV from a bloody toilet seat? And it's amazing to see people create all these incredible scenarios. I was like, let's be real for a minute. If you, as a black person, walked into a bathroom and there was blood in the bathroom, how long would you be in the bathroom? They kind of get it. So that's the way we kind of reduce stigma for people.
So it is about people telling their stories. It's about people understanding more about what it is that they need to do. But again, going back to everything you said, All of this information is out there. We're working with groups. We are educating them, but we're still seeing the problem of stigma and shame. And I think that you mentioned, Vaughn, about the role of the faith-based institutions. We here at the National Black Leadership Commission on AIDS recently launched a stigma and shame campaign. And we are focusing a lot on what the faith-based institutions can do in order to break it down. And that involves a lot talking about it, what it is, the impact that it has on a person, trying to at least get not only the persons who might be infected, but those who are around them, their family members, their fellow congregation members, to see the negative impact that this is having, and also helping people or leading some people to decide not even to get tested because they don't want it known in terms of being HIV positive. So, but there's so much more we've still got to do. And how do we get our arms around this now? What is it, Doc, we need to do? Come on, talk to me.
Okay, I look at it and from the point of view of an individual.
Okay.
And then I look at it from the point of view of a group. One of the things, the conversations that I have with my clients is the fact that your responsibility, because you have become infected, is to make sure you educate as many as possible. Only a person with the experience can really talk about what it is that happened to them. I've had women who basically came to me, and the way she was diagnosed is I decided to give her an HIV test when I opened her mouth and I looked in her mouth. Her husband had died a year or so ago. She did not know that her husband was HIV positive for the last 5 years of their marriage. And he had unsafe sex with her. She wanted to know nothing about HIV. I couldn't tell her about her infection. I had to treat her blind. The only thing she allowed me to do is to talk to her sister, because I says I can't just do things to you without somebody involved. So I was talking to her sister down south whenever I needed to do something with her.
How long did that go on?
That went on for 5 years. And what I think it slowly over time it ate at her is that she stopped taking her high blood pressure medicine and those kind of medicines, and she eventually died of a heart attack. She did not die from HIV. She died from the fact that she was betrayed by her husband. And that is my take on it, but nobody else may not agree.
So it's about education, but it's also about responsibility.
Exactly. And that's why I like the churches. Okay, so I've been talking a lot, especially at Abyssinia. I've done a couple of talks at their faith-based programs.
Right.
And I like the fact that they're out there doing something and they're bringing it into the church. In terms of the Methodist Church, for which I belong, I basically strong-armed quite a few pastors, and I give the conversation about HIV. And one of the criteria that I have given is that I will tell you the truth whether or not you like it. And if you want me to water down the truth, I cannot do it. And one of the things I hold the churches accountable for is the negativity in their under-breath comments. Oh, look at her. Look at what she's wearing. You know she's one of those. Oh, look at him.
They say that in church, Dr.
They say that in church. And those are the kind of things that basically let a person knows if I come to church and say HIV positive, the first thing that's going to happen is that undercurrent, under-breath conversation is going to tear me apart before church even gets 5 minutes in.
One of the things I will say about, because of course in our organization, National Black Leadership Commission, as you work with over 100 or more churches right here in New York City. And I have found that over a period of time, it goes back to that education and building those relationships, that more of the clergy are speaking more boldly from the pulpit about HIV to the congregation, not just around the national testing days or the national commemorative days. And I'm finding that the messages are received very differently, even at prayer time, praying for people who are sick, including those who have HIV and AIDS. So there are different ways that I'm seeing it worked in that I have to believe is having an impact. Now, you mentioned the campaign, Vaughn, that you're doing now. You want to talk just a little bit more about that?
Sure. We're looking at revising our campaign, which last 2 years really targeted working in the faith community. So we talked to pastors and leaders of the church about These are scriptures that often are misinterpreted as canons of sexual morality, that often the object of that sexual morality is men.
Yep.
If men make the difference, then church step up and talk about what it means to live differently. So this new research project is actually trying to find a way to make this curriculum more standardized, to actually talk about the measurements of prejudice. And so we show ways in which prejudice is a thought generated from the Bible. We ask people, why do you believe it's so? And then show that when you act on this prejudice, it becomes discrimination and has a negative impact. This discrimination has a reverse effect, effect for you if you're a church member. And then we talk to people about whom they lie to most. And they're surprised. It's like you lie to yourself most. You lie to your clergy member, you lie to your doctor. The three people that you should be most honest with, you don't tell the truth because you're afraid of their judgment. So we talk to leaders, remove the judgment, and as a faith leader, give that person who's just found that they were positive the ability to forgive themselves for becoming positive. And the pathway opens to have a more wholesome conversation.
Yes.
So I know that we all are on the right path on this, but I think what we've got to do still is to expand that base, expand it more, because sometimes we end up talking, like they say, you know, preaching to the choir, singing with those who already know the song, and that we need to expand that base, and that's where I think all of this hopefully is leading us. So in the few moments that we have left, why don't each one of you give some contact information so that if someone wants to follow up with you and do further work, become a patient, or become an advocate, how would they contact you, Dr. Long, real quickly?
Okay, I'm at Renaissance Healthcare Network. I'm located at our Drew Hamilton Center, but I'm going to give you our main number, which is on 118th Street, our Sydenham Clinic, and the telephone number is 212-932-6500, and our community liaison person is Alicia Moy, and her number is 932-6532.
And how can someone contact you, Vaughn?
Sure. We're Brooklyn-based, so our number is 718-222-6300. Our website is www.gmat.org.
Thank you. I'd like to thank Dr. Carol McLean-Long and Vaughn Taylor for joining me on today's program, where we discussed some steps that we can all take to overcome the shame and stigma surrounding HIV and AIDS. For more information on this project and issues related to HIV, AIDS, and other health disparities, please visit NBLCA's website at www.nblca.org or look for us on Facebook and Twitter. The Manhattan Neighborhood Network brings these programs to you to better inform you, the viewer, about the important topics that impact your health and well-being. Please let your friends, family, and neighbors know about this important programming. Once again, I'm C. Virginia Fields, and I thank you for joining us and hope you'll tune in next time for NBLCA's Health Action TV here on Manhattan Neighborhood Network.